I'm Alberto Montero, and today I'm going to discuss the new approval of pembrolizumab in the neoadjuvant setting and also review the data from the MonarchE study, which led to the adjuvant approval of abemaciclib in high-risk ER-positive HER2-negative breast cancer. Here we see the FDA approval timeline for both drugs. Abemaciclib was initially approved in the metastatic setting in February of 2018 by the FDA, only to be later approved in the adjuvant setting for high-risk ER-positive HER2-negative breast cancer much more recently in October 2021. Pembrolizumab, by contrast, was initially designated FDA breakthrough status in October 2019 and then approved in the neoadjuvant setting July 2021 as a result of the Keynote 522 trial. In the metastatic setting, pembrolizumab was approved in November 2020 for PD-L1 positive triple-negative breast cancer. Unlike the FDA indication in the metastatic setting, pembrolizumab in the neoadjuvant setting, the recent approval in July of this year by the FDA, is independent of PD-L1 status. It is for all early-stage triple-negative breast cancer, and this is on the basis of the Keynote 522 trial, which showed a benefit of adding pembrolizumab to neoadjuvant chemotherapy that was independent of PD-L1 expression. It is also important to note that the label makes reference to continuation of pembrolizumab in the adjuvant setting as per the Keynote 522 trial. Before I discuss the Keynote 522 trial, first I would like to present a case that demonstrates the type of patient this new pembrolizumab indication is precisely intended for. Patient JE is a 51-year-old woman who was recently diagnosed with clinical T2N1 grade 3 triple-negative breast cancer. She had a mass in her left breast that measured approximately 4 centimeters. She had biopsy-proven axillary involvement. Her performance status was excellent, and she had no other medical comorbidities that would make neoadjuvant chemotherapy contraindicated. Genetic testing was performed and negative for BRCA1 or 2. This is the study schema for the Keynote 522 trial, and there are a few important points to note here. First of all, patients with high risk defined as tumors 2 centimeters or greater in size or lymph node involvement, early stage triple negative breast cancer, regardless of PD-L1 status, were randomized in a 2-to-1 fashion to receive a standard neoadjuvant chemotherapy, which involved weekly paclitaxel and either weekly or every 3-week carboplatin times 12 weeks, followed by AC every 3 weeks times 4 cycles. Patients either received placebo or pembrolizumab and then went on to receive surgery. The primary endpoints were PCR rate, pathologic complete response, and event-free survival. Key secondary endpoint was overall survival. It's also important to note that pembrolizumab was continued adjuvantly every 3 weeks times 9 cycles. This slide shows the primary endpoint, pathologic complete response rate, in the Keynote 522 trial. This is taken from the original publication in the New England Journal of Medicine by Peter Schmidt and colleagues. And as you can see on the top row, pembrolizumab, the addition of pembrolizumab to standard neoadjuvant chemotherapy was associated with a significantly higher pathologic complete response rate, 65% versus 51%, for a difference of approximately 14 percentage points, which was clinically and statistically significant. In addition, pembrolizumab was also associated with significantly improved event-free survival, which in the Keynote 522 trial, as we can see here on the left, was defined as progression of disease that precluded surgery, local or distant recurrence, second primary malignancy, or death due to any cause. And as we can see in the Kaplan-Meier curve to the right, pembrolizumab plus chemo was associated with an 18-month event-free survival of 91% versus 85%, with a hazard ratio of 0.63, which was clinically and statistically significant. The addition of pembrolizumab to standard neoadjuvant chemotherapy was associated with higher toxicity. As we can see here in a table from the original New England Journal of Medicine paper, pembrolizumab plus chemo was associated on average with grade 3 or greater toxicities that were 5 percentage points higher than in patients who had received chemotherapy alone. Most of these toxicities, of course, are immune-related toxicities. Here we see the same toxicity data, but shown in a different manner. In the light and dark green are the overall incidence of different treatment-related adverse events in patients who had received pembrolizumab and chemo, and in the red, dark red and lighter red are those that received chemotherapy alone. The darker colors designate grade 1 to 2 toxicities, and the lighter color shades are more severe grade 3 to 5 toxicities. And as you can see, compared side to side, there were no major differences between toxicities. Again, there were slightly higher toxicities with pembrolizumab that were essentially immune-related in certain areas, such as diarrhea and increased transaminases. Here we see the immune-related adverse events, or iRAEs, in the Keynote 522 trial, and as we can see here, the most common iRAEs were with pembrolizumab in the study were infusion reactions, hypothyroidism, severe skin reactions, and hyperthyroidism. Fortunately, grade 5 toxicities such as pneumonitis and adrenal insufficiency, these quite severe toxicities, were very uncommon and were in line with what has been seen in prior studies. To summarize the safety data in the Keynote 522 trial, commonly reported adverse events were similar between both arms and were mostly chemotherapy related. There was increased toxicity in the pembrolizumab arm in excess of 5 percentage points. This is in line with other phase 3 trials that are ongoing in triple-negative breast cancer, specifically IMpassion031 and NeoTrip, which of course utilize a different PD-L1 monoclonal antibody, atezolizumab. Treatment-related fatal AEs, or grade 5 AEs, were fortunately rare in Keynote 522, 0.4%. And this again is in line with what was reported with NeoTrip and IMpassion031. It is important to note that while serious iRAEs occurred at a similar rate with other studies, it's important that we notify patients that some of the endocrinopathies can result in lifelong requirement for monitoring and supplementation. The new neoadjuvant indication from pembrolizumab was not made on the initial publication of Keynote 522, but was made after data reported at this year's ESMO virtual plenary, which I wanted to briefly review. Here we see the event-free survival curve from the updated analysis presented at this year's ESMO, and we can see that the event-free survival curves continue to widen. Here showing data at 36 months with a median follow-up of 39.1 months. As you can see here on the right, the event-free survival rate is favoring pembrolizumab at 84.5% versus 76.8%. Hazard ratio 0.61, and again, this is clinically and statistically significant. While event-free survival, as defined in Keynote 522, includes non-metastatic events, it is important to note that what's driving the difference in the event-free survival curves in favoring pembrolizumab is related to a significant reduction in the rate of distant recurrences. As we can see here, the rate of distant recurrence is 7.7% versus 13.1% in the chemo alone arm, which is about half. The number is higher, but of course keep in mind that this was a 2-to-1 randomization, so twice the number of patients were randomized to pembrolizumab chemo than the chemo alone arm. Here we see a Kaplan-Meier curve of distant relapse-free survival, and we can see it with the updated data at 36 months. There's a widening of the curve with a distant relapse-free survival rate of 87% associated with pembrolizumab and chemo versus 80.7% in the chemo alone arm, hazard ratio of 0.61. Although it is still premature to see overall survival differences in the Keynote 522 trial, here we see Kaplan-Meier curves presented at this year's ESMO with the updated data from Keynote 522. And at the 36-month mark, we can see that there is a beginning of separation of the curves favoring pembrolizumab, 89.7 versus 86.9, hazard ratio of 0.72, which was statistically significant. Here we see event-free survival from Keynote 522 broken down by pass CR rate. And what's most striking is below. So in the cohort of patients who did not achieve a pass CR, the addition of pembrolizumab at the 36-month mark was associated with a much higher event-free survival rate, 67% versus 57% for those who received chemo alone. And although you do see a difference in the cohort of patients who have a pass CR, it's much more modest. And that's not really surprising, since we already know from meta-analyses and prior studies that patients with triple negative who achieve a pass CR with neoadjuvant chemotherapy have a survival in excess of 90%. It does have implications in the adjuvant portion, since all these patients received adjuvant pembrolizumab. Longer follow-up may help answer whether or not patients who achieve a pass CR will require continued pembrolizumab. And although my presentation has been focused entirely on Keynote 522, this slide is to highlight that there are 3 other neoadjuvant trials looking at the value of adding immunotherapy to neoadjuvant chemotherapy in triple-negative breast cancer. You have the IMpassion031, which we have some results showing the addition of atezolizumab to chemo did statistically improve pass CR rates. We don't have the secondary outcomes yet. We also have the NeoTrip and NSABP-B59, where the results are still pending. So to summarize, Keynote 522 demonstrated that the addition of pembrolizumab to standard chemotherapy in triple-negative breast cancer resulted in significantly higher pathologic complete response rates, something which has also been shown in another phase 3 trial, IMpassion031, and with a different drug, atezolizumab. Keynote 522, its co-primary endpoint, event-free survival, also demonstrated that the addition of pembrolizumab resulted in significantly higher event-free survival, primarily driven in patients who did not achieve a pathologic complete response rate. Overall survival, although early, did show a significant benefit of the addition of pembrolizumab. The toxicity profile was manageable, and there are no new safety signals seen in Keynote 522 that have not been seen with other immuno-oncology drugs. There are several unanswered questions. First of all, because in Keynote 522 patients benefited regardless of PD-L1 status, there is a question of who really needs immunotherapy. There is a great need for predictive biomarkers. The chemotherapy backbone needs to be optimized. In this trial, the overall sequence, where platinum was given with taxane before anthracyclines, and AC was given every 3 weeks instead of the traditional every 2 weeks. So there's questions regarding what is the optimal chemotherapy backbone. Finally, there are some adjuvant IO trials that will be reported in the next few years that I think will be informative. And these are the ABRAVE, the IMpassion030, and the SWOG S1418. Next, I'd like to discuss the phase 3 data that led to the new indication for abemaciclib as adjuvant therapy. So on October 12th of this year, the FDA approved abemaciclib in combination with endocrine therapy as adjuvant treatment in patients with hormone receptor positive, HER2-negative breast cancer who are high risk, defined as node positive, and that have tumors with a Ki-67 score of greater than or equal to 20%. They also approved a companion diagnostic with this indication. What's interesting is if we contrast this with the pembrolizumab, which I just discussed, which did not require a biomarker or companion diagnostic. In this case, this approval is being tied to expression of Ki-67 with a specific companion diagnostic. Before I discuss the MonarchE study, I would like to present a case. GM is a 49-year-old premenopausal woman who had presented to my clinic with right-sided breast cancer, clinically measuring 5 centimeters. She also had palpable axillary adenopathy. Biopsy of the axilla and breast revealed grade 3 invasive ductal carcinoma, ER positive 80%, PR positive 5%, HER2 negative. A mammoprint was done, which revealed a high-risk mammoprint tumor that was also luminal B. Initial CTs were performed, which were negative for distant metastases but did demonstrate internal mammary nodal involvement, which gave the patient a stage of clinical T2N3. The patient underwent neoadjuvant chemotherapy with dose-dense AC times 4, followed by weekly paclitaxel times 12, and underwent surgery. The patient had a residual 3 centimeter tumor, moderate chemo effect, and 5 out of 10 involved nodes. Germline genetic testing had been done, negative for BRCA1 or 2 mutations. GM demonstrates the type of patient that the new indication of abemaciclib was intended for, provided that her tumor is also Ki67 positive. Cyclins and cyclin-dependent kinases are key controllers of the cell cycle. 15 to 40% of breast cancers exhibit cyclin D1 amplification or overexpression, which leads to suppression of the tumor suppressor RB and ultimate release of transcription factor E2F, which promotes cancer cells passing through the first cell cycle checkpoint. Therefore, CDKs are a good anti-cancer therapeutic target in breast cancer. CDK inhibitors such as ribociclib, palbociclib, and abemaciclib in combination with endocrine therapy have been shown in phase 3 trials to prolong progression-free survival and in some studies overall survival. Consequently, the MonarchE study was designed to evaluate the impact of adjuvant abemaciclib in combination with endocrine therapy on disease-free and overall survival. The MonarchE study was a randomized phase 3 trial in patients with hormone receptor positive, HER2 negative, node positive, early stage breast cancer that had 2 different cohorts. In cohort 1, patients who had high clinical pathologic risk factors for recurrence were enrolled. This was defined as 4 or more axillary nodes, or in patients with 1 to 3 involved axillary nodes, were required to have either tumors that were grade 3 or 5 centimeters or more in the greatest dimension. Cohort 2 included patients solely based on Ki67 expression. So in this cohort, patients with 1 to 3 positive axillary nodes and tumors that were positive for Ki67 by central lab, 20% or more, and had grade 1 to 2 tumors and tumors that were under 5 centimeters were enrolled. Patients were randomized in a 1-to-1 fashion to either abemaciclib 150 milligrams twice daily for up to 2 years with standard of care endocrine therapy or standard of care endocrine therapy alone. Patients were stratified for prior chemotherapy, menopausal status, and geographic region. The primary objective of the MonarchE study was invasive disease-free survival. Key secondary objectives included invasive disease-free survival in the Ki67 high population, distance relapse-free survival, overall survival, and safety. Here we see the patient characteristics in the MonarchE study between both arms. As you can see, both arms are balanced with respect to age, menopausal status, prior chemo, number of axillary nodes, tumor grade, and Ki67 index. I'd like to draw your attention to this line. In this study, in the MonarchE study, approximately 60% of patients in both arms had 4 or more axillary nodes, so this is definitely a very high-risk population of patients. I also want to draw your attention to the Ki67 expression. So in both arms, approximately 45% of patients had a Ki67 index of 20% or greater. Here is the disease-free survival Kaplan-Meier curve from the original JCO publication. At the 24-month analysis, we can see that the addition of abemaciclib was associated with a significant improvement in disease-free survival, 92% versus 88.7% for endocrine therapy alone. If you look at the inset, you can see the hazard ratio is depicted there. The hazard ratio of 0.75 is clinically and statistically significant. Depicted here is the 2-year distant relapse-free survival Kaplan-Meier curve from the original JCO publication. Again, you can see that the addition of abemaciclib to standard adjuvant endocrine therapy was associated with a significant improvement in distant relapse-free survival, approximately 94% versus 90%, with a hazard ratio of 0.72, again, which is statistically and clinically significant. Similar to the Keynote 522 study that I had presented earlier, where pembrolizumab reduced primarily distant recurrent events, we see a similar trend here with abemaciclib. Shown in the red rectangle, you see that abemaciclib is reducing primarily distant recurrence events, less so local regional recurrent events, compared to endocrine therapy alone. In this slide, we see the updated 3-year disease-free survival Kaplan-Meier curves presented by Nadia Harbeck and colleagues earlier this year. On the left, we have the overall intention to treat curves for the entire study. As you can see at the 3-year analysis, the Kaplan-Meier curves continue to widen, and the addition of abemaciclib to endocrine therapy improved 3-year rate of disease-free survival from 88% to 83%. The hazard ratio is shown below, which is 0.70 and is clinically and statistically significant. On the right, for the Ki-67 high subset, we see a similar trend with the widening of the disease-free survival curves and a hazard ratio of 0.66, which is clinically and statistically significant as well. This slide shows the updated 3-year invasive disease-free survival in MonarchE in cohort 1 by Ki-67 status. The red represent patients who received abemaciclib plus endocrine therapy. The blue represent the control arm, patients who received only endocrine therapy. The solid lines represent patients who had Ki-67 high tumors, and the dotted lines Ki-67 low tumors. As one would expect, because Ki-67 overexpression is a negative prognostic indicator in ER-positive breast cancer, patients with Ki-67 high tumors did worse than those with Ki-67 low tumors. As one can see here at the 3-year analysis, patients benefited from adjuvant abemaciclib regardless of Ki-67 expression. In Ki-67 low tumors, the 3-year rate, disease-free survival rate was 191.7% versus 87.2%. In the Ki-67 high subset, the 3-year rate was 86.1% versus 79.0%. In other words, the benefit of adjuvant abemaciclib was seen regardless of Ki-67 status. However, the magnitude of the benefit was greater in Ki-67 high tumors. The benefit of abemaciclib comes at a price, and this is increased toxicity. As you can see here, in the MonarchE study, the addition of abemaciclib to standard endocrine therapy was associated with an increase in grade 3 toxicities of approximately 31 percentage points. As expected, the most common toxicity noted in MonarchE was diarrhea. The incidence of grade 3 or greater diarrhea in the MonarchE study was approximately 7.6%, with an early onset, a median onset of 8 days. The median duration of grade 2 to 3 diarrhea was short-lived in the MonarchE study, only being 5 to 6 days, and the discontinuation rate due to diarrhea was low in the MonarchE study, only 5%. To conclude, the MonarchE study demonstrated that adjuvant abemaciclib added to standard adjuvant endocrine therapy significantly improved invasive disease-free survival in patients with hormone receptor positive, HER2 negative, and node-positive breast cancer that are at high risk of early recurrence. Although the benefit was seen regardless of Ki-67 status, the benefit of adjuvant abemaciclib was greater in the subset of patients who had Ki-67 tumors that were greater than 20% positive. Results are still immature. The median follow-up at the original analysis and at the additional follow-up were 19 and 27 months respectively. Only 39 or 1.4% deaths were observed in the abemaciclib arm and 37 or 1.3% in the control arm. Grade 3/4 toxicities were increased with abemaciclib, 33 percentage points higher compared to endocrine therapy alone. However, these toxicities were primarily related to diarrhea and largely reversible. Finally, I would like to thank the organizers for the opportunity to present today. I also would like to thank all of you for your attention. I look forward to answering any questions that you might have during the live portion of this seminar. Thank you.